We have Agent Rocha here. I think you're probably going to get a lot of feedback from the team here, I'm sure, for your case.
I'll just
well, Agent Rocha is preparing for one of our difficult cases here. You can see he's already moving around now. Okay. Oh, you got the glasses now. Okay.
I'm going to just stand a little bit to wake up everyone.
Because you're scared of Rosa.
I'm scared of Rosa. Yeah, I'm going to stand over here.
I understand.
All right.
Take it away, man. Take it away.
So
I understand.
this episode is called The Miniature Ghost. So as you know, in the medical justice system, we need to declare our conflicts. These are my conflicts.
Viewer discretion is advised.
So this episode is based on an actual CSI episode called The Miniature Killer. And you'll see here Agent Grissom using a microscope kind of thing. And this episode actually had the killer replicating the crime scenes. You see him using jeweler's forceps. There's the eye, there's the link. And so this is the actual case. Does anything look unusual there or suspicious for anyone? They look innocent to begin with. It looks pretty innocent?
Pretty innocent to me.
All right. So we'll start with clue one. And so this is the right eye that was found. There's a compound hyperopic astigmatism, plus 150, plus 275 at 10 degrees with a corrected vision of 20/32. But the patient sees, I see a ghost. So this is what was found. This is at the crime scene. Any comments there on what that could be? Make it a bit bigger? No? That's the residual evidence. Contact lens? Okay, let's keep going. Agent Massacott brings a witness.
What exactly did the patient see? Was it a dark crescent? Was it a white light?
So he's seeing a ghost, so it could be a dark crescent, a dark or a white light, right? Think harder. What about this? We'll keep going. It says, the patient, the witness said, I see this photo up there, dysphotopsia. All right. So this takes us to the crime scene investigation of dysphotopsia. So now we're concerned with the crime scene investigation. We need some help from Horatio.
No kids, no gun. He must have grabbed a knife for self-defense. What the hell's happening here?
Frank, it's called crime scene investigation.
Okay. So you did a background check. What did you find?
So between 20 and 50% of patients will have some form of dysphotopsia after an uneventful cataract surgery. Fortunately, for most of them, it is only a transient problem.
Usually happens after uneventful surgery. Most of these visual phenomena will resolve without intervention. Okay, Agent Rosa, tell us what you found about dysphotopsia.
Well, there's negative dysphotopsia, which is typically a dark temporal shadow, or a positive dysphotopsia, which they can see as shimmering lights or streaks or halo. And traditionally, everything comes from the temporal side because the nose nasally will block the light going in, and they don't really describe the phenomenon nasally. It's more of a temporal phenomenon.
Okay, so this helps you a little bit in explaining a little bit more.
Right, so it's whether the light gets reflected back in and bounces back into the retina, and then you can see that as a dark temporal edge, or whether it gets reflected down or back out, and then you see that as shimmering lights.
Okay, so we have negative and positive dysphotopsias. I brought another witness as well who saw the same thing. This is closed caption.
Yes, I saw it too. Streaks of light and dark, like a comet.
Like a comet. Like a comet, okay? So positive dysphotopsias, we're getting now into the area of high order aberrations. There can be coma, which give you blur and double vision. So depending on the spherical, or depending on the high order aberration, you'll get different symptomatology. So you can have coma with blurred double vision. Spherical aberration can give you glare and halos. Trefoil gives you starbursts. And secondary astigmatism gives you mixed focus. But that coma, it's easy to remember, coma, comet, they usually go hand in hand. And with some of the current diagnostic testing with topography and aberrometry, we can actually identify some of those. You see in the box, in the white box, you see the different aberrations described, and then you see some of the symptoms that the patient may have. So it usually correlates well with the clinic. Any comments from the team?
I was saying, Agent Rocha, what kind of technology are you using here?
This is an eye trace.
How does that work?
That's a topographer aberrometer, and it's with ray tracing.
Great.
Yeah.
Good to have the latest technology with us on our team.
Exactly, exactly. And now, when does these become significant? So significant doesn't mean that we all have high order aberrations of some level, but really it becomes moderate to severe symptoms once we get past 0.3, 0.4 microns. All right. Now we have a sketch artist depiction, and this is a very important thing I'd like you to look at. So you see the symptoms there, you see the comet shape, but we really had to use digital technology to enhance this. And as we started enhancing, we found something that was really interesting. And all the boss, they're trying to frame you. They're trying to frame you.
This is a total setup here.
We won't let that happen.
No way out.
All right, no way out. Any ideas at this point? So far, we can conclude, okay, the patient has dysphotopsias. These are positive dysphotopsias, and that something was removed. Was it a contact lens? Was it an IOL? Any ideas? An IOL. Well, let's see. We have a press conference now. We're going to get help from the public, so we can go to the questions. So, are the positive dysphotopsias caused by the lens? That's A. The lens was defective, and that's why it was removed. Positive dysphotopsias were not caused by the lens. The lens was never in the eye. That could be two. And I don't want to name any suspects at this time. Were not caused by the lens. Okay. No, they're still voting.
While the results are coming up, you know what's always amazing is how many patients actually experience these. We just don't ask about it.
Yes,
and,
that's right.
We only hear about the patients who actually have figured it out, but I would argue a lot more patients actually notice this transiently in the first few days.
Exactly. All right, we can look at the results. Yeah, that's 63% thinks that the positive dysphotopsia were caused by the lens that was removed. Perfect. So that's one of the things we'll look at. Now, clue number 2.
So can I just piggyback on that?
Yes.
Piggyback on that point. Guillermo and the rest of our team here, how many of you think that if someone complains of a positive or negative dysphotopsia, how long do you wait before you would consider the lens being the problem and explanting? How long do you think is a fair time to ask the patient to see if they adapt to it?
I usually say 4 to 6 weeks.
4 to 6 weeks.
I'm usually a bit longer because the studies have kind
At
of
least.
shown that you'll get 40 to 50% will report it at day 1. It'll go down at 1 week. It'll go down at 1 month, and 6 months it can be down to less than 5%. So I try to tell them to wait if they can. I know that we have some pretty high expectation patients out there, but I generally try to wait a little bit if I can. Often they'll resolve or they adapt, whatever the reason is.
Yeah.
Well, even with multifocal lenses, we tell them sometimes 2 to 3 months, and they adapt in most cases.
I usually say at least 3 months, if not even a little bit longer, if they can tolerate it. And it depends on the patient personality, obviously, but if you can at least let them know they're not crazy, some of them are, but if you can at least let them know they're not, they feel better about that if you validate their symptoms, right? So to say to someone, oh no, that can't be happening, that doesn't make sense. But if we validate them and kind of handhold a little bit and say, it is a true phenomenon, people do experience this, it can be experienced in 50 to 80% of patients on day 1 and whatever, they feel a little bit better. And I find sometimes at 3 months, either they don't complain about it anymore, they might still see it, it's just they've gotten used to it, or it's gone away.
Yeah.
Especially, negative dysphotopsia is a pretty discrete, specific finding that we can, correlate to the lens often. Other things don't give it usually, like cornea issues we don't think the incision relates to it or pupil or anything else. But positive dysphotopsia, which in my experience is more common, glare, light sensitivity, I mean, we all know that can be a lot of different issues, ocular surface, other causes. You need to get that time to kind of get better and improve before jumping in and saying it's the lens. And in fact, taking a lens out of somebody who has some glare may not actually resolve the problem. Unless
Exactly.
it's, you know.
And that's why we continued questioning family, friends, and significant others, and we rounded up the usual suspects. Who is Kaiser Soze? You guys are too young for that movie, maybe. So, is it the iris? So, causes of dysphotopsias: iris, IOL factors, retina uveitis, neurological factors, patient factors, as well as corneal factors. So, this is Agent Rosa. What are the differential or causes of the IOL causes of dysphotopsias?
So you want to make sure that the IOL is actually in the bag and that there is overlap and the amount of overlap. And that can be very tricky because sometimes too much overlap or too little overlap can cause a dysphotopsia. If they have an uncorrected refractive error, they're more likely to get those positive dysphotopsias that I talked about, the glare and the haloing effects. A high plus cylinder caused by proliferative lens fibers or streaks on the posterior capsule can cause a dysphotopsia. Or if you have a decentered IOL that can shift over, you can also have a little crescent that's caused by that decentered IOL between the iris and the lens, and that can cause a dysphotopsia as well.
Excellent. So those are IOL causes of dysphotopsia. Agent Massicott, IOL causes of dysphotopsia. Can you continue with these ones?
When a lens has a high index of refraction combined with a low radius of curvature, it can cause reflections from the internal back surface of the front of the lens. Square edges, as we said, incomplete rhexis overlap, and vertical haptics can also cause dysphotopsia.
So can you comment a bit more on the vertical haptics? How does that happen, and how would you fix that?
Well, actually, I make sure that they're always horizontally oriented at the end of my cases.
Okay, and why is that important? Because if the light hits here, if the haptics are completely horizontal, then there's a bit more space there, so there's less chance of reflection, right? And how would you fix that if you had vertical haptics and that you think that's the cause of the dysphotopsia?
It depends on the timing. If it's 1 month post-op, I would go back.
Okay. And so, through the magic of Hollywood, we can do that.
Now, Agent Guillermo, can I ask you a question about in-the-bag placement?
Yes?
There's some controversy around that, and some would argue you see it less with maybe complicated surgery, like a sulcus IOL or a 3-piece optic capture, and you see it more with in-the-bag placement.
Yes, because of the distance between the posterior cornea and the iris and the lens itself. So it depends on anatomical factors as well.
You know, the other tip I'd like to talk about with dysphotopsia is particularly if it's related to a light source. Is it a light source that's like right in front of the patient, like primarily, or is it like from the ceiling or tangential? That could sometimes give a clue to where the problem is.
Exactly.
Whether it's from the edge of the lens, or whether it's from the material, or whether it's you know, from a differential aperture size in terms of the IOL edge.
Okay. So then we looked at those factors as well, and whether the lens was in the bag. So there are other causes as well that could happen during surgery. For example, pupil size, pupil irregularities, the Flomax use, and whatever damage happens or can happen during surgery, iris damage, as well as posterior synechia. And then there's also IOL dysphotopsias with some of the known associates, including design, material, damage to the lens, multifocal lenses, iris IOL distance, as you were discussing, anterior edge of the capsular rhexis as well. And then, of course, there can be worse with different materials and square edges, and they can also be worse with higher
index of refraction
as well.
Oh,
Exactly.
wow, you guys are
Well
that's
synchronized.
teamwork.
Well
That's
synchronized.
teamwork.
They were up late last
I like
night.
her.
But now look at this. This is what happened at the time of surgery. So we're going back, remember? So we found that piece of IOL or something. Now we have a picture of the actual surgery. And really there was a normal pupil size at the time of surgery. There was no damage to the iris and a normal capsular rhexis. The IOL was in the back.
So I want to make a quick comment. I see sometimes this is missed. Even some small transillumination defects, they may be subtle to us. They appear not significant. In some cases, they can, I think, cause issues. So to determine that, if I see some transillumination defects temporally, I'll take a pen light and try to focus it in that area and compare that to, for example, the other side of the iris. And sometimes patients elicit that. And that sometimes can be repaired with an iris repair or something like that.
Okay. Excellent point. So far we can conclude that cataract surgery was uneventful. The IOL was placed right there. And so let's see if we can narrow it down. Remember, you first said that the IOL was not the cause of the dysphotopsia. So let's see. Which statement is correct? They were caused by the lens, they were caused by the iris. I'm not yet sure why I got so early. Exactly. Okay. We'll keep going. But look at all the causes. Was it the lens, the iris, the cornea, or neurological factors? And we can switch back now. Thank you. So clue 3. So this is clue 3. We have clue 1, clue 2, and there's only 3 clues. So we're going to move. So Mr. Haggis was brought in for questioning. We couldn't find Mr. Barrett. He was away on holiday. All right. All right. So is there any difference between the two parameters here? Do you notice that? So look at the difference in the astigmatism in the right eye, and this is the left eye. Compare 1.91 on the left, 6.26. Look at the Ks as well, 42, 48, 43, 45. Wow. Okay. Do you see a difference between these two? This is the right and the left eye. Okay, what was that? This? Some scars. Okay, they look like scars, but what do you? Well, so let's focus a little bit. This is the guilty guy. This is the innocent guy. And you can see there's extra Purkinje images, right? Any ideas on that? So here it is. What is that? Which one? Intraocular contact, okay, phakic IOL. Okay, so there's a phakic IOL, and we can see that here as well. There is cataract. So this is before. We're still going back in time. Remember, like in a CSI episode. So this is a cataract, and this is the ICL. That's the edge of the ICL. Right. Any comments? All right. So what happened here? So we brought another witness. What did you see? You know, we don't have all day. What is your name? The guy said, well, my name is Howard, but they all call me Hawa, H-O-A, high order aberration. All right, that's the name of the suspect. And you can see here, we talked about 0.4 being significant. You see the changes here in the simulated E, and you see that comet kind of shape in the patient. So, of course, we took this back to the lab. All right, we're talking about high order aberrations. All right. All right. We go back to the body of evidence.
Made for TV.
Well, we had to go to the lab, and we asked Horatio to help us with this. Well, we have to wake up everyone. Yes, good, good. So he worked on this, and we retro-engineered what we found, the evidence, into that. So that's a phakic IOL. We were able to obtain the evidence in this way. So, any ideas? We can conclude that what was removed originally was a phakic IOL, and there were significant high-order aberrations. Okay? Any comments from the team?
I mean, in the presence of a cataract, you will get whole eye aberrations routinely, right?
Mm-hmm. Yes.
So
then the question is, what happened? Why did we remove? Why did the patient have high-order aberrations before, or after, or at both times? We'll bring it all together. Any thoughts at all? Okay, we'll keep going. So right now, let's narrow it down a little bit more. Who do you think is the culprit? So is the ICL, was it the one that caused the high-order aberrations? That's why we removed it? Is it the cornea? Is there dry eye, basement membrane dystrophy, keratoconus? Was it the cataract, as you were saying? It increased high-order aberrations? Was it in their minds, like Kaiser Sose in the movie? Or still not sure. So ICL caused the high-order aberrations. Some say it's cornea-related, and some say it's cataract-related. So most of you think it was the cataract that was related. Okay, good. let's go back in time. So we found some more evidence. A note had been left in 2003. And so the guy at that time was saying, so this is way before any of these surgeries. I can't take it any longer. Blurry vision, double vision, starburst, ghosting, can't wear contact lenses, can't wear glasses. He was really suffering and struggling. That was the note that they left. And so we got Mrs. Zernicki and her opera singer Son Placido, like Domingo, and showed some revealing information. That looks like the topography you showed before. Yeah. So what do you think? Any comments there? There's a lot of distortion. Okay, so this is way before anything else had been done. So let's keep finding a little bit more. Agent Massicot, what are some of the corneal causes? So everybody agrees now we're sort of narrowing it down to the corneal causes of dysphotopsias.
So they can be caused by corneal edema from the wound or from high pressure. Of course, dry eye is always a classic suspect.
Okay, so you've got these three cases: corneal edema, high water content, dry eye. What about Agent Rosa?
Well, just like when looking at toric IOLs and looking at the cornea, you want to look for epithelial basement disease that can be going on. You really want to look for keratoconus or even a form first of keratoconus that can be occurring, and any higher order aberrations that may be there.
Okay, so let's go back and try to put this a little bit more together. That was 2013. So this patient then had a procedure, including cross-linking and therapeutic laser. And then this was 2017, before any other further interventions. But we now can start seeing that there are changes on the cornea. We were able to regularize the cornea a little bit more. And really...
Agent Rocha, if you can go back to that, it looks like you were probably running from the crime scene when you took those pictures.
Well, those are historical photos.
Okay.
Those are historical photos. That's why I gave it this sepia and the kind of...
Okay.
It was for effect, for the Hollywood effect. All right, so you're ready for the profile.
I believe a word he said.
So these are some of the profiling basics. You don't have to know that. This is also just to fill in. But we'll bring the clues together to identify the issues. We have dysphotopsias, which are present. A lens was removed. We have cataract surgery, which was uneventful. The lens was well placed. And we also have a phakic IOL. Now we know that IOL was a phakic IOL and there was significant high order aberrations. I know you're all newbies here, but I've had previous experience in some similar cases, so I will help you through this. We have an unsub that's at the middle of the controversy, which is the phakic IOL. There's different aspects of dysphotopsias, a lens, and a well-performed surgery, but I'll show you the timeline. So the dysphotopsias were there before the ICL was placed. Then the ICL was removed in preparation for cataract surgery. Cataract surgery was fine, and there were still some remaining dysphotopsias afterwards. So the underlying issue is keratoconus. Okay? So that was the underlying issue as a corneal cause for dysphotopsia. Explains why positive dysphotopsias were present, although reduced after cataract surgery. Keratoconus and cataract both, that was a point the boss made here, both can contribute and were contributing in this case. And the main high order aberration to remember in keratoconus is coma. And as you can see here, this patient, this is the whole eye, this is coma, this is the internal aberration, there was some coma, and this is also some coma there. So coma is the one to remember. But we still have to deal with the residual, right? This is where we started, with a compound hyperopic astigmatism. And so the three messages I would like to leave you with is, first one, identifying it pre-op. We discussed the fact of needing a topography in every case, cataract case, especially if you're planning AKs or if you're planning toric lenses. IOL dysphotopsias are most common, so it was a good thought going down that route, but the reality is that they were not the issue in this case. And then a couple of points I want to make about IOL calculation in keratoconus. So I'll address some of the negative issues with dysphotopsia. These are more likely to resolve. They are more common than positive ones. And they have different causes, as you can see here, with IOL design, anatomical factors, the edge of the rexus, and we can exchange it or place it in the bag. These are some of the treatment options that you see there. On the other hand, positive dysphotopsias are more disabling. They're less frequent, and they're more related to the design of the lens, and you usually have to remove the lens. Now, in terms of calculation with keratoconus, the thing to remember is that we will be erring on the positive. So you see in this case series, they all ended up positive, positive, hyperopic, hyperopic. So an easy strategy is to plan more negative. So plan for about a -1, -1.5. Because of the changes in the shape of the cornea, it's a hyperprolate cornea, and it actually changes the Q or A sphericity, but it also changes the Gulf-Strand ratio. And it's a weird combination because it really is not necessarily intuitive, but we have a hyperprolate cornea. Now, this is a very nice article that I also found. Up to about 55 diopters, you can plan on what I said, -1, -150. However, if the cornea is steeper, the average corneal values are steeper than 55, if you do that, if you take these cornea values, you will get a very myopic result. And so, or actually a very hyperopic result, 6.8. And so what you would have to do really in these cases is just pick a 43.25 standard keratometry reading for your calculations, and you should be better. So there's a difference between how steep the cornea is. You can see the result there. So to summarize, use total corneal power, consider the Q value. Remember, the cornea is hyperprolate. And remember, IOL calculations result in hyperopia, and the plan in keratoconus eyes is target a myopic result, use the measured Ks up to 55, use standard Ks of 43.25 when the Ks are higher than 55, and you may consider using spherical or neutral spherical IOL, depending on the spherical aberration. The final outcome of this patient, all of this was discussed with the patient. This is a patient I've dealt with for about 6 or 7 years. So it's a long-term relationship. We knew at every step of the way what the plan was. He was happy with his contact lens fit with the help of an optometrist, and improved uncorrected vision, corrected vision, and he has had stable keratoconus with a 20/20 vision and resolution of his positive dysphotopsias to a comfortable level. So
That was well.
that's it.
Quite a similarity there. So,
That's why I wrote
question here: you had performed cataract surgery was performed with a patient who had an ICL in,
Yes.
right? So, what formula did you use to calculate the IOL power in this case?
The same. I don't make any. You mean in terms of taking into account that the ICL is there?
Yeah.
I mean, I think we used the Barrett in him, and I used my usual strategy.
So my only concern with that is that the AC depth is artificially shallow.
But it's not. It hasn't been an issue.
Because what I typically do is I typically either try to measure with OCT what the endothelium to anterior crystalline lens distance
That would be
is. Because you do lose about 1 millimeter or so, right? So again, a shallower AC, the formulas may potentially knock off a bit of the power. They may, right? Especially the ones that take into account AC depth.
Okay.
So that's one question. And of course, there's also some refraction of light through there, but that's minimal though. The refraction of light through an ICL is minimal. So I think there's probably more work. I looked up some of the studies on this one.
Okay.
And so that's why I typically go back to using 2 variable formulas with those.
And so would you, like in this case, IOL Master 700 seems more advanced, but it's OCT based. You think it's actually detrimental instead of using just a purely optical?
It depends what you enter for your AC depth,
Yeah.
I think. I think you have to be careful. If your AC depth is 3.3 millimeters or so, that's actually an artificial AC depth. And the formula is based on what they expect crystalline lens AC depth to be. That's just a small
And that's
thought.
but that's a good point, because it may be that having more sophisticated equipment may not be necessarily, in some cases may not necessarily be better, because it does take into account that other factor and would explain part of the hyperopic result.